Hello everyone, and welcome to our weekly podcast brought to you by VJOncology. This week, we will be covering updates in checkpoint inhibition beyond PD-1 and PD-L1 for solid tumours. First off, we have Jesus Fuentes-Antras from the Princess Margaret Cancer Center in Toronto, who discusses the rationale behind developing Inca 32459, a bispecific antibody targeting PD-1 and LAG-3, and the advantages of co-targeting LAG-3 and PD-1 over individual targeting.
I think that's one of the key questions. So I won't elaborate again on LAG-3 and PD-1 by themselves. I think these are very well-known targets and actually validated, for instance, in melanoma. So the goal here was to explore, to show that a bispecific may have several benefits. And what those benefits are, essentially, is first, from a biological rationale, is to have a more efficient modulation of the immune synapse by co-targeting at single cell level. Second, I would say from a PK/PD perspective, this is not a combination of two different agents, but just one. So we may understand that PKs are going to be more predictable and pharmacodynamics as well. And a third, this is going to be directly related to the fact that dosing is going to be easier. So in terms of development and achieving higher doses, the development should be easier. Finally, this as well would lead to higher doses, more efficacy, but having less toxicity at the same time, because we'd be more efficient in these co-targeting. I think these three key aspects are the points to highlight why we need to develop these specific targets.
He also presents results from a first-in-human trial that assessed the bispecific antibody in patients with select advanced malignancies.
So this was a first-in-human phase 1 trial studying these molecules LAG-32459 in selected malignancies and focused in melanoma, particularly. This was a PD-1 LAG-3 bispecific, which is one of the novelties, not just the targeting of both signals, but doing it with a bispecific, which is different from other approaches which are already validated. I think in a nutshell, the rationale is there to target LAG-3 as a co-inhibitory signal, which is co-expressed with PD-1 in T cells, which are exhausted. So what we want to do here is essentially to overcome immune resistance, either primary or secondary. This trial enrolled approximately 50 patients, most of them, well, not most, but in the highest proportion were melanoma, triple-negative breast cancer, nasopharyngeal carcinoma. And we saw from a safety perspective that there was not a big difference compared to previous targeting of PD-1, for instance, the PD-1-PD axis. Essentially, I can recall the DLT was achieved, and we saw 2 cases of myocarditis, which were fortunately quickly resolved with steroids. And the rest of the side effects were easy to manage, not limiting, and again, not very different from what's already established. And in regards to efficacy, this trial showed approximately a 20% overall response rate, and approximately 45% of DCR patients achieving stability. And we may consider these results in light of the fact that 2/3 of the patients have previously received and progressed to immune checkpoint inhibitors, which makes them particularly valuable. Finally, saying from a PK/PD perspective, there were no relevant signals in the sense that PD-1 occupancy was observed, PKs were linear. I mean, there was nothing really extraordinary from that. So suggesting that pursuing further development of the agent would be a good idea and a good potential. Unfortunately, this trial was stopped early, but this was essentially due to a sponsor's decision and in line with their pipeline strategy, but not due to safety concerns or other issues in terms of efficacy and pharmacology.
Next up, we have Laurence Buisseret from Institute Jules Bordet, Brussels, who comments on recent advancements in checkpoint inhibitors and ADC combination therapies in breast cancer.
Several ADC have been approved in all breast cancer subtypes. First, it was with TDM1 in the advanced setting of HER2-positive breast cancer. Then TDM1 moved to the adjuvant setting for patients with residual disease after neoadjuvant chemotherapy. Then we had the approval of TDXD in advanced HER2 breast cancer. And then more recently, sacituzumab govitecan in triple-negative breast cancer. And now more recently in luminal breast. Immune checkpoint blocker in breast, it's only approved in triple-negative breast cancer, both in the advanced setting, but also in the early setting. The combination that has been already reported at ASCO in June is with sacituzumab govitecan and pembrolizumab. So in advanced triple-negative breast cancer, patients with PD-L1 positive tumor in first line are treated with a combination of chemo and pembrolizumab. In second line, it is sacituzumab govitecan as monotherapy that is the recommended treatment. So in the ASCENT-4 trial, they evaluate in first line the combination of sacituzumab govitecan, the ADC targeting TROP2, and the anti-PD-1 pembrolizumab. So patients were randomized between sacituzumab govitecan and pembro compared to chemo-pembro. Of note, only a few patients that were included received pembrolizumab in the neoadjuvant setting. So as you know, now pembrolizumab is used in stage 2, stage 3 early TNBC. So here in the ASCENT, while the approval arrives during the trial, only 4 to 5% of the patients included received this neoadjuvant pembro. So in these patients that were immunonaive in first line with PD-L1 positive, 2/3 were recurrent, 1/3 were de novo disease. The trial demonstrates an increased PFS from 7.8 months for chemo-pembro to 11.2 months for sacituzumab govitecan and pembrolizumab. Overall survival are immature, but already this PFS advantage is really encouraging. Of note, patients that progress in the control arm were allowed to receive sacituzumab govitecan in second lines as it is recommended. So with this crossover, overall survival will be difficult to really demonstrate in this trial. So there are other combination of ADC and an immune checkpoint blocker that are under evaluation in breast cancer, both TNBC, but also in the luminal, also in HER2 disease, and also the combination move to the neoadjuvant setting. So in the neoadjuvant setting, the goal is to achieve a PCR. Patient with complete pathological or complete response, we are more moving in the mood of de-escalation of treatment to opt immunotherapy because we know that patients that achieved a complete response have a very good outcome, while patients with residual disease, even if they receive immunotherapy, they have a high risk of relapse. And in this setting, there are some trials evaluating the combo of ADC with immunotherapy as rescue therapy, and we are waiting for the result. There are also trials evaluating the combination in the neoadjuvant setting to improve the PCR rate.
She also discusses checkpoint inhibitors and ADC combination strategies in urothelial carcinoma, citing the recent approval of enfortumab vedotin and pembrolizumab.
So yes, at ESMO IO, there was a special session within the industry on antibody-drug conjugate. Are they immunotherapies? And my talk focused on ADC and ICI combination in solid tumor. So there are a lot of trials ongoing, already some results that are known specifically in advanced urothelial carcinoma with enfortumab vedotin and pembrolizumab, which is now approved in this indication since December 2023. So that first-line treatment for patients with locally advanced metastatic urothelial carcinoma, regardless of cisplatin eligibility. So this is really a new standard of care, and it is the first ADC and ICI combination. There is also another approval in China with a Chinese ADC. So the combination in urothelial carcinoma is moving now in the neoadjuvant setting. At ESMO a few weeks ago, we had the presentation of the result of the EV303. So it is neoadjuvant enfortumab vedotin and pembrolizumab, this time in the neoadjuvant setting for patients with cisplatin ineligible muscle invasive bladder carcinoma. And it demonstrated, but it was compared to observation, that this neoadjuvant treatment with ADC and pembro increase the PCR rate, event-free survival and overall survival. There is a trial ongoing that compares this neoadjuvant regimen to chemotherapy for patient with cisplatin-eligible muscle-invasive bladder carcinoma.
Finally, Yuxiang Ma from Yat-Sen University Cancer Center in Guangzhou, China, discusses updated results from a phase 1/1b study of QL1706, a bifunctional PD-1 CTLA-4 dual immune checkpoint inhibitor.
QL1709. The drug is dual inhibitor, which we call bifunctional inhibitor, inhibition of PD-L1 and CTLA-4. This drug is published. The previous results was published in STTT, Signal Transduction and Targeted Therapy, in 2024, the early, maybe March or February. Yes. So what we doing now, what we submit abstract and doing, the submission of this article is the updates of efficacy and the predictive biomarkers of the QL1709. Also, this article was published in Cell Report Medicine. I remember it's November of this year, just a month ago. Yes. So this drug, the background we can see this drug is combined immune checkpoint inhibitor. It's PD-1 and CTLA-4, but it's a difference from bispecific. Bispecific antibodies is different from, we know, the cadonilimab or other like O plus Y, the treatments. It is a bifunctional map pair products. What we know about map pair is like a medical engineer techniques. It can, put the anti-PD-1 and anti-CTLA-4 antibody in 2 versus 1 with untruncated CTLA-4 antibody half-life is smaller to reducing the immune-related adverse events. As we know that the most of the AE, the very serious adverse events when we combine PD-L1 and CTLA-4 is mainly due to the CTLA-4. If we reduce the CTLA-4's half-life, it would be much, much less of the adverse events, especially for the immune-related adverse events. So when we do these products, when we do, a map pair products, we can control the CTLA-4 antibodies, the proportion of the CTLA-4 antibody, and we can to construct it to reduce its half-life, which ultimately lead to a very less of immune-related adverse events. This drug is conditionally approved by NEPA. NEPA is a Chinese FDA. So in our trial, we can see the results. QL1709 was the phase 1 clinical trial was performed in 2020 March to 2021 July. Is also including 2 phases: phase 1 study and phase 1b study. Phase 1 study is a dose escalation study. Phase 1b study is dose expansion study. In phase 1 study, the dose escalation stage, we enroll about 132 patients was screened, and 99 patients was enrolled. So in the phase 1b, we found that 5 milligram per kilo is the RP2D. So we do expand in 8 different kind of solid tumors. Totally, the 419 patients was enrolled, including different solid tumor type, including non-small cell lung cancer, including nasopharyngeal carcinoma, including cervical cancer, and etc. So for this, the reason the main contents of this article is the updates of the survival of all those of this trial. Totally about 500 patients. It's about 518 patients. So that's the updates efficacy I can show you now. I can read out to you is the objective response rate about 70%, including all those levels. The median duration of response is very long. It's over 1 year. It's 12 months, 12.4 months. The median PFS is short. It's 1.5 months, which is the most important thing for QL1709, the monotherapy treatment. Nearly 14 to 50 patients, 50% of the patients progress early on, which why we do need when we conduct the phase 2 trial and phase 3 trial, we have to put QL1709 plus with chemotherapy or ADCs. The monotherapy have a very serious issue. That's nearly half of the patients couldn't benefit from early on. But when the patients, when they stay in the trial, do not progress from the first or second month of the treatments, it have a very long of the duration of the response. That is very astonishing. You can see, although nearly 14 to 50% of the patients progress early on, it also has a very long median OS, which is for whole patients is over 1 year. It's 14.6 months. For the immunotherapy naive patients, the duration of the response is nearly 13 months. The median OS is over 1.5 years. For those have immunocheckpoint inhibitor pre-treated patients, the median duration of the response is about 10.4 months. It's also very long. The median OS is about 1 year. It's 11.5 months. So that is the updates of this trial. What is most importantly, this trial was accepted and published in Cell Report Medicine is because we have done a very sophisticated of the translational research. We have collected those patients, the sample of those patients, including non-small cell lung cancer, nasopharyngeal cancer, and cervical cancer, and we do the DNA sequencing and the RNA sequencing. So what do we do now? Why do we do this translational research? We do the PD research because I've introduced previously that about 40% to 50% of the patients will progress early on. If we can trial the treatment upon a baseline, we can exclude those patients from the treatment. Then we can significantly increase the beneficial for these patients enrolled in this trial. We can avoid those patients who are not have any benefits from this therapy.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.